All right. All right. So we're at that hour for the April 19th of the 2023 edition MSTS webinar series for our fellows. We've had some pretty awesome talks leading up to this. This is a talk that kind of takes us in a little bit different direction, and I think it has some very important content, but at the same time, it's also content that is easy to overlook unless you're actually at a point where you're forced to kind of come to grips with some of the concepts in here, and that's the considerations of how we intersect medicine and law, the medical legal considerations, especially with the mindset of being a surgical oncologist. And I think I titled this as being familiar with the process and protecting yourself throughout that process. This will be recorded, and hopefully we'll also be sharing the slides as a reference. And I also will plan to share some of the articles that you can peruse if it is of interest to you in the future as well. I think that, let's see here. Obviously, any talk, I think it's important to update disclosures. None are at all relevant to this talk. I am a paid consultant for a few companies, and I do work on one of our committees with the Academy as well as the MSTS for registry purposes. So I think it's one of the things when it comes to medical legal understanding is it can be a pretty cloudy space. There's, especially living in the United States of America, but also lots of countries, there's a fair amount of wide liberal interpretation of what constitutes an injury, what constitutes deviation from standard of care. What is standard of care? That's something that we can't even agree on in many cases. And as you can see from each of these pictures, you can have a pretty egregious, standard of care of a backwards, implant, or a nail through, in our world, a nail through a pretty obvious malignancy, or a very common scenario in what we see as orthopedic oncologists is incomplete excisions. A third of our practice will be that in our careers when it comes to soft tissue sarcoma. You can see X-rays that look really funny, but patient seems to be doing okay, and maybe it's not necessarily medical malpractice, probably not what you would have done. And then there's also the concept that you can't put in a picture, and that's what the delay does. What is the damage that occurs, or the loss of chance that occurs because there's a delay? And as we'll see across a very recurrent theme is delays in diagnosis when it comes to the world of cancer malignancy. So any important talk, I think, is good to outline what we're about to touch on. And my goal is to not necessarily dive too deep down the rabbit hole, but to scratch the surface on each of these. And I think you first got to understand the foundation of some of these concepts. What does it take to have a lawsuit? What is the standard of care? Let's define it. Maybe some definitions or ideas of what even medical malpractice types that will be introduced to as a new surgeon. And then going through the process, what happens when you get deposed, and what hat are you wearing during a deposition? What happens if you're an expert witness? What do you bring to the table there? How do you document? How do you confront other surgeons that may send you things that are unfortunate circumstances? Obviously touching a little bit on what happens when you're in the hot seat. And then what are some common scenarios just to be on the lookout for in oncology? We focus mainly on sarcoma related because there's not a whole lot out there that specifically focuses on surgical oncologists in the cancer world. So I think that this is a slide I actually use in a lot of talks. I've obviously switched a few of the pictures around, but I think it's a slide that really gets to what we do a lot of, and that's the concept of you walk into a situation, you feel like you're pretty familiar with it, everybody seems harmless, whether it's in the operating room or in the aftermath, but then you start to understand the fact that maybe something didn't quite go right, and maybe you don't take it quite seriously enough, and all of a sudden a lawyer gets involved, and you have that intersection of doctors and lawyers. Oh, you know what, I know what I did, and I'll be able to explain it. And I think the purpose of this talk is to help us avoid and understand what might be lurking beneath the waves, so we don't end up in a situation like this. It's really rare, and I want to emphasize this. I put this at the beginning of my talk. It's very rare to get sued. I think it's more common than it was in the 1980s and 1990s. We are certainly becoming more of a litigious society, but at the same time, when it comes to medical malpractice, at least, it is becoming more and more rare. And part of that is because of tort reform, and part of that is because lawyers are becoming wise to the fact that some things just really aren't worth the effort of going after. And especially, I will take that even further as a surgical oncologist. Some of the papers we'll look at will say that it's even less likely that you'll be sued. When it comes to cancer, it's generally not a surgical train or an oncology trained surgeon that is going to be the highlight reel part of a lawsuit. So starting with that important concepts is the medical malpractice or tort action. What's the definition of a tort? Well, a tort, it's an act or an omission that gives rise to injury or harm and amounts in a civil wrong that's different than a criminal wrong in which courts impose liability. Okay, and in order to have a tort or in order to have a medical malpractice suit that can move forward, you have to have 4 separate parts, which we'll break down just for a minute, and then I'll stop to take a few questions. You have to have a duty, dedication to a standard of care. You have to have a breach of that duty. So a duty has been set, it's now been breached. Then you have to prove that there's a direct cause and effect, and that has led then to the final part of that tort reform, and that's damages or injury has occurred. So each of these is something that is carefully scrutinized before a lawsuit is even brought to full fruition. And I did throw one other part in there, and that's the concept of informed consent. That's not necessarily one of the 4 parts of tort action, but it is something I think we need to talk about. And I put a pretty, hopefully powerful example to understand, like, can we really get informed consent in some of the things that we do? This is a good article. I shared it. It's an older article, but law hasn't changed. You know, it's been around since the medieval times. Some of these concepts that we talk about, and it really goes through each of these concepts. And I think the definitions are here. I'm not going to spend tons of time on each of these slides, but these slides will be available as references. So duty is defined that once you enter into a relationship with a patient, you see the patient, you agree to take their care in some way, shape, or form, whether offering an injection, whether seeing them back for surveillance, whether operating on them, et cetera, that you have now entered into a duty to the patient. And the standard of care is now defined as a physician who exercises that same care, or the same care in a reason, as that what a reasonably prudent physician would have exercised under a similar condition. And I think it's really important to understand that obviously standard of care varies based on specialty and even as far as subspecialty. Obviously, you're going to be held to a different standard when you're on call fixing a blown apart pilon fracture than what a traumatologist may be held to. Same thing from an oncology standpoint. Standard of care is objective, but it's not fixed. It can shift and move over time. It can shift just from state to state. It can shift from country to country. Obviously, what is available, training, resources, all plays into that. And it's also important to prove that the plaintiff, the person bringing the complaint of the injury, bears the burden of establishing what the standard of care is. They oftentimes will plaintiff will bring in experts or expert testimony to establish this and any type of persuasive evidence to do such. And I think, again, that some of these highlights in the boxes I put, the standard of care is not intended to identify one specific best practice, but encompasses a range of treatments that might be considered acceptable, again, within the context of what is being discussed. The second part of a tort action that's necessary is that breach of duty or negligence, we call it. A physician conduct falls below that professional standard of care. And examples of breach of duty, or what you'll often see in some of the articles that we'll talk about, we call them complaints, are either a misdiagnosis, oftentimes a pathologic misdiagnosis, a delay in diagnosis, by far the most common reason that lawsuits are successful, a surgical complication such as a loss of limb, etc. There is a concept that I threw in here, and again, this goes back. Law is really holds foundation back to the medieval times, dating back to the 17th century. This res ipsa loquitur, which essentially is Latin for that thing speaks for itself. It's so egregious and so obvious that it speaks for itself. And I put an example: the patient undergoes an appendectomy and awakes with a paralysis of one arm. Well, if that patient hadn't gone to sleep and hadn't undergone the surgery, well, then the paralysis of the arm wouldn't have occurred. And the problem is with that, and it's becoming less and less favorable or used, that concept is that just because you have a bad outcome doesn't necessarily mean that you have breached duty, that negligence has occurred. And that may fall short of allowing you to move forward with a tort. The third part of a tort that is necessary is causation. So a breach of this standard of care directly caused an injury, okay? And there are two parts to this causation. One is called cause and fact, that an act must have been necessary for the outcome to have occurred, even if there might have been other confounding factors in such and such a thing. And an example there: somebody with very brittle bone has a wrist undergoes a femur fracture, and during positioning breaks the wrist. Okay, well, the surgery caused it, but it was also because of the setup for poor bone quality. But proximate cause is another part of the causation that's used when lawyers are looking at this, and there has to be some kind of a timeline that makes sense. You can't go back four years or 10 years in the rear and say, oh, that action caused me to have such and such an injury. The remote action cannot constitute a present damage. And that is a reason, a protective reason actually, in many lawsuits, that proximate cause can get that part of causation thrown out as lawyers are trying to show the four parts that constitutes a successful tort action. The final part is damages, or the injury. What is the loss of chance that occurred? So these are losses occurring directly because of the breach of duty. These damages are intended to make the plaintiff whole, these damages that are awarded. So there's different types of damages. There's compensatory damages, which is specifically saying we're not looking at anything else except giving you back what you lost, okay? Then there's special damages, which typically are medical bills and lost earnings, which are also fairly commonly awarded. The punitive damages and the non-economic damages. So non-economic damages are kind of this nebulous concept. You'll hear about it. Oh, the pain and the suffering and the emotional toll. And it's really hard to put some kind of a number on that. And that's where things can get out of hand when it gets to a jury pool, because now you have a bunch of quote peers, which really have no understanding of the concept, and they don't have a tangible way to put a number on it, offering exorbitant amounts of money. And then punitive damages, when emotion gets into it and jurors are angry at somebody and they want to make somebody pay, that's when the physician's actions are so egregious that they want to just give money just to stick it to them. And that's those non-economic and punitive damages are when you really see these mounting awards. So those are the four parts of the tort action that we talked about. And I told you we talk about a fifth one, and that's informed consent. Informed consent, especially in what we do as orthopedic oncologists, the sacrum, the shoulder girdle, some of these surgeries, it is literally impossible in my mind to have a patient who is a lay person who has not had the training, not had the experience, not seen the complications, not seen the collateral sacrifice that occurs in order to get a cancer out, truly understand what is about to happen to them in the aftermath. The five parts in a simplistic way for an informed consent are: you got to give them a diagnosis, you got to describe what you're going to do to the patient, why am I doing it, how long is this surgery going to last, how am I going to do this, what are some types of implants I'm going to use, what are the chances of success that we can get your cancer out, that we can save your function, etc. Sometimes we're really, really good at guessing that, and sometimes we're not. Sometimes surgeries can be 2 hours or 10 hours, and that's hard to know until you get in there. All the material risks, is this really possible to really go through, like, what are all the possible risks that can occur with this operation? And I would argue that the answer is no, it's not possible with some of the surgeries we do. Is there any reasonable alternative to this procedure, which makes sense? And then what are the risks of not being treated? Okay, so if you go through all of that, that obviously takes a chunk of time in your clinic. And when you're getting crammed in 5-minute and 10-minute slots, how do you have that conversation when you have a patient that walks in the office with something like this, where you have to do a massive operation, you have to get 3 or 4 different surgical teams involved. This may be a 2-day surgery. They're going to wake up without a foot that works. They're going to have potential for non-union, for infection, for bowel and bladder and sexual dysfunction. And you walk away saying in a 20-minute conversation or even in an hour conversation, I really feel like that patient was able to offer an informed consent. And that becomes tricky. It really, really does become tricky. So I think that's an important thing just to ponder on when you're seeing some of these big operations and things. And the final part, and then I'll pause for questions from concepts, is just a real basic overview of what medical malpractice insurance coverage is. I think this is also important, not necessarily for needed for tort action, but also like this is what protects you. And it's claims made type of medical malpractice insurance and occurrence medical malpractice. Those are the 2 basic forms. 90% of physicians out there are covered by claims made. This is generally private practice doctors, and claims made provides coverage for incidents and claims, so the actual event that occurs and the claims that are filed during a policy period. So once that policy period expires, it is no longer covered unless you purchase tail coverage, which we'll talk about in a second. Occurrence is a much more expensive way. Generally, employers or hospital employers will do this, but still, it's only about 10% of coverage is occurrence coverage. And this is where claims are made during a policy period, and any claim or event that occurs during that policy period, even after the policy expires or you move on to another hospital, et cetera, that follows you. That occurrence follows you the entire way. And as you can see, I just again some negatives and positives, benefits of each one of these. So, with that said, one final concept that I wanted to throw on here, and we'll talk about this in a second, this article, but the concept of tort reform, which I know we hear about all the time. But this was an article that was looked at in 2014 that showed in sarcoma, we went state by state. 3 states which did not have tort reform at the time, or sorry, 4 states which did not have tort reform at the time, about 50% of all litigation over a 30-year period occurred in just 4 states. But when you went and looked at each of the damages that were awarded, as well as the percentage of success with the plaintiff outcome, tort reform, so-called tort reform that the states would trumpet, did not actually appear protective against either the outcome or the award amount. And that's, again, sarcoma specific, very rare, but something to keep in mind. And one of the reasons for that is that there are certain injury claims that actually fall outside tort reform. So in the cancer world, wrongful death or loss of limb, oftentimes, and this still holds true today, will fall outside of actual tort reform. It's kind of an outlier that's not covered, so to speak. And so punitive damages, like we talked about, the non-economic and the punitive damages can be astronomical sometimes in these types of cases. So with that said, can I pause for a moment? Any questions or points of clarification that I can make?
I have a question, and I know you're going to get to this. I think when you're talking about standard of care, and one of the things I think I had questions on when I was younger, and now that I hopefully have gotten a little older and more mellow, is the concept of standard of care as an expert. When you're asked to be an expert witness, and what is standard of care amongst us as orthopedic oncologists, and what really is standard of care for an orthopedic surgeon? That 33% of patients that presents with an incomplete excision, and then you get asked to be in a deposition as the treating physician, or you're asked to be an expert witness. And how do you think differently about standard of care for the average orthopedic surgeon as opposed to you as the orthopedic oncologist? And I don't know if that makes sense, but
it does. No, it does. And I think there's a lot of variables that when you're asked, especially asked these questions on the fly, it's hard to answer. Like, for instance, there's an article out there that talks about the education of general surgeons and orthopedic surgeons. And about 85% I believe it's about 85% of orthopedic residents have some kind of formal, let's just say, sarcoma training. less than a third of general surgeons do. And if you look at what the literature would suggest, it's the biggest offenders of, let's just say, incomplete excisions aren't necessarily orthopedic surgeons. They're general surgeons, plastic surgeons, people that don't actually have that formal training. But who's to say that orthopedic surgeon that is in the hot seat that you're asked to be the expert witness wasn't in that 15% that never had a chance except to go to maybe like a 2-day course to pass the OITE, and has never even seen a real sarcoma. I think that's a variable that's really hard to understand. I also think I think that when you have something that may not necessarily affect overall survival or outcome, and I think that's in the cancer world, that's what we care about, I think, the most, is something egregious like a loss of limb is obvious, but probably so, like, am I going to die because of the mistake that you just made? And I think that it probably is a little bit easier to be softer on that standard of care if you can clearly look and say, listen, like, yeah, this wasn't ideal, but this can be remedied. And maybe you don't have to be so hardline on that standard of care that's necessary. And then I think the final thing, Ginger, it would be like historical precedent. You look at what England has done. They've spent tens of millions of pounds over a decade plus trying to educate the entire country in a socialized system, which should be very easy. Everybody's kind of corralled. And at the same time, they look back 10 years later, the size of their sarcomas haven't changed. The referral patterns haven't changed. They're getting a lot more referrals, but a lot of them, they're almost to the opposite end, where people are so freaked out that they're not taking time to actually evaluate and look at the red flags. They're just sending everything, no matter if it's benign or not. And so history would suggest that no matter how hard you try to educate, things still don't change. So how can you become a hardline on that standard of care?
Thanks.
Yeah. Any other thoughts out there? Questions from the fellows? Otherwise, I'll move on. Okay. The deposition. Okay. This is I think, an important concept to understand, because at some point you're going to be in a deposition. Whether it's you're building a house and something goes wrong, whether it's your actual professional practice, whether it's something that happens in your life, but you're going to have to talk face to face to a lawyer in some way, shape, or form, whether it's in a courtroom, a pre-courtroom, etc. And there's really 3 scenarios where you're going to be deposed. And this is, again, in our professional hat sense. As a defendant, okay, hopefully that doesn't happen. As I said, that happens very rarely, but you're in the hot seat. As a treating physician, but non-defendant, so you were part of that patient's care, but you weren't the one that was that is the eye of the inquiry. And then as an expert witness. And I think it's important to understand that each one of those has a different hat that you wear. And this is another good article I put on there. And I put on this because there are some important things. This was based on some research that has been done. It was actually written by an attorney in the Yellow Journal, of looking at, like, for instance, what are some concepts? For one concept that in the research suggested that higher paid expert witnesses were seen as hired guns and therefore less trustworthy. Another poll of jurors that had gone through over 100 medical malpractice cases, that poll came back and said that jurors rarely believed that the defendant lied or exaggerated. And jurors believe that physicians who display a more caring attitude, whether it's in the deposition or on the stand, will make better decisions. And so jurors, again, really don't have a ton to latch onto, but they latch on to kind of that emotion and that attitude and that human beingness of the physician. Expert witnesses are also oftentimes perceived to cancel each other out. They're kind of like 2 rooks on a chessboard. Eventually, they cancel each other out, and so that other pieces can go at it. And jurors ask themselves 4 questions. And I think this is important. You always know the mind of your enemy, or not necessarily enemy, but the mind of your opponent. Who can I trust in this lawsuit? If I were in a medical crisis, not a medial crisis, but a medical crisis, would I be safe in the hands of this person on the stand? Under the circumstances, did this physician do the best that he or she could do? And did that physician make the proper medical decision? So those are the 4 questions that jurors are asking themselves in these types of cases when they're leading to the deposition. So in the first hat, you're the defendant in the lawsuit. Okay, these I would use these. I would keep these handy, but there are some rules that you should live by. And do not stray from this. Number 1, I made it bigger for a reason. Give the absolute shortest, truthful answer. This is not your time or place to mount your defense or offer an explanation in the deposition. You will have your time in court when you're brought to the stand to do that. But in the deposition, you give the shortest, truthful answer. If you do not know, you do not guess. You say, I do not know. You stay away from superlatives. I never do that. Or, oh, I always do this. Stay away from that kind of stuff, because what it does is it puts you on a lofty pedestal that jurors want to all of a sudden assume you've lost that humanness. Now you're putting yourself up on Mount Olympus here. Never lose your temper. You always are allowed to take a break if you need one. Never forget that. If you are shown a document, do not feel rushed. Read it thoroughly. Check the date, check the signature, make sure that you look at it. And if you do not remember seeing that document, do not guess, and be very clear. I don't remember this. I'm sorry. And never, ever answer a question you do not understand. And one of the things I want to emphasize with any of these is lawyers are rarely doctors, meaning there are a few MD, JDs out there, but lawyers are not doctors. And so they may ask questions that make no sense medically. And it is absolutely okay, especially as an expert witness, but even to some degree as a defendant in a lawsuit, to kind of steer them and say, I'm not sure I understand that. Did you mean this? And put it more into appropriate medical context. Okay. Any questions on that as a defendant? Number 1 is by far and away the most important. You can really tie your own noose by being too wordy. As the treating physician, but non-defendant in the lawsuit, okay, your job as you're brought to the deposition table with the camera is to tell the information as you know it. This is not a memory test. This is tell the facts. You're testifying about your knowledge of the patient as you saw them, and you can review the medical records. You feel comfortable with the course of care ahead of time, and you can go in there and do nothing but be a fact teller. Okay, this is probably, in many senses, probably the easiest of the 3 chairs to sit in when you're in the deposition. But it's still an important part that you could potentially be subpoenaed for. And that is an important point I just wanted to throw in there. We hear the word all the time. They're on legal shows. You saw Perry there from Suits. A subpoena is a legal document that if you get this from a court, it is an absolute mandate that you show up for court or the deposition, because you are required. The one side or the other believes that you are going to bring some kind of tangible objects to this legal proceeding. Okay, it's time sensitive. You must respond to it. Do not ignore it. Silly, simple concept, but a lot of times we haven't seen this when we're fellows.
Quick question.
Yeah.
Okay. For the deposition, like the situation that you just said, is that mostly when you are going to have like one of your partners or a referring physician that you were involved with their care, like after the fact, and you're trying to just give the story of what's going on? Is that kind of what that?
Yeah, exactly, Julie. It's probably not going to be your partner. It's probably pretty rarely your partner,
Okay.
because the lawyers are smart too. They don't necessarily want to bring somebody in that might have some impartial bias one way or another. But it's that second hat that we talked about, the non-defendant physician is somebody who is there as kind of a witness, so to speak. Not an expert witness in so much that I'm going to kind of build standard of care for you, but I was there. I saw what happened. Let me just be a storyteller as to the chain of events in my professional eye.
Okay, cool. Thank you.
Yeah. Thanks for joining tonight. So expert witness is the third hat that you wear. And this is a hat that we all have potential to be part of. We sit in a very small community of experts within ourselves. There's probably only 200 to 300 of us in the country. So there's when musculoskeletal oncology related lawsuits occur, both the plaintiff and the defendant side are looking to build standard of care and to create a narrative. And in order to do that, you have to have a witness to help build that foundation. And the first thing, I put this slide there, this well-known Eastern Asian, the art of war, know your enemy, know his sword. A good attorney, when you walk into that deposition box as an expert witness, is from the onset is looking to put you in a very tight box that you have no room to wiggle out of. They are trying to set your expertise in as narrow of a window as possible. And anytime you stray out of that lane, they are looking to discredit everything. Once they can find one flaw, everything else, it's kind of like a drop of poison poisons the whole well. And so that is what their goal is to do as an expert witness. Your role as an expert witness, when you walk into that, the mindset that you have to have is you are there to educate the jury. You get up there, you qualify yourself, you give your qualifications. This is time to brag, frankly, in terms of what you have done to deserve the expert role that you've been given. Okay, your scholarship, your training, etc. Okay, and the rules that when you're an expert witness are to ground your opinions in the qualifications. Okay, realize that you have bumpers to stay in, but those bumpers may be wider than what the lawyer is trying to give you. And I'll give you an example. Dr. Holt, I see that this is a soft tissue sarcoma case, and you're an orthopedic oncologist. Well, yes, I am. Are you a radiologist? Were you trained? Did you do a fellowship or a residency in radiology? Well, no, I didn't. Well, how do you have qualifications to read this and interpret what a soft tissue sarcoma looks like? Well, as it turns out, this is my entire practice. I interpret every single MRI advanced imaging study that comes through. I sit down with my radiologist. I look at every one. I give my own personal opinion or personal interpretation of these. I go through it with physicians, and over 26 years of experience, I can interpret these as well as a radiologist can. Now, all of a sudden, you've widened your bounds. Traumatologists will do the same thing. In orthopedics, we do a lot of our own X-ray interpretations, and as oncologists, we do CTs and MRIs more than some of our colleagues do. Okay, this is a time. Remember, I told you when you're a defendant, shortest truthful answer. When you're an expert witness, it is okay to be more professorial. Okay, you want to establish your expertise. You want to kind of build a gravitas to say you should listen to me as to how I'm building this standard of care. Okay. And as I said, number 4, I've already talked about this. It's okay to correct lawyers. They may not use terminology correctly, but you can correct them. You can rephrase the question, and you can be more liberal with this as an expert witness. Okay. Any questions on those? And then I just wanted to do a quick fee structure on an expert witness. Okay. So fee structures. I don't want to spend a ton of time on this, but I just put on at Cleveland Clinic. I sent them actually I've done a few of these expert witnesses, and these are the emails. I literally put it verbatim. All requests must go through the legal department. You cannot collect a personal fee. If anyone calls you requesting you to serve as an expert, you must basically call us and run everything through us. That, when you work for, especially an academic institution, is probably as much as the fee structure tip as you're going to get. You're not going to get paid a dime to do this, but it does help build your awareness. It helps sometimes build the prominence in terms of the field. You learn a lot of stuff doing this, and you become more confident in some of this. It can be fun, frankly, at times. Now, if you're an independent practitioner and you have the ability to do that, this is an example of a fee structure, okay, where you can literally create a contract. And I'm actually, Dr. Holt is actually this is kind of her line. I'd love to turn this over to her and give her, if we could get some tips and tricks from you. But this is just an example of how you might be able to creatively structure this in order to say, yes, my time's valuable, but absolutely, I'll play ball with you.
Yeah. What usually happens is you'll get an email request that says, my understanding is you're an orthopedic oncologist. We have a case we'd like for you to review. If you're interested, please send us your CV and fee structure. and we'll contact you if it seems like a right fit. So the fee structure is basically is laid out here. There's an initial review cost because you're going to have to go through a lot of likely a lot of images. You may be going through a lot of depositions. There's a lot of reading and actually a lot of time that goes into it. Even when you get fast and efficient, they're going to want to set up a phone call with you afterwards. And some of the important things that you learn through this process are that you should never make notes. You should never email anything back, put it in writing. It should all be phone calls and as little documentation as you can, because some of the first things you'll be asked when you're an expert witness are, did you make any notes? We want those. Did you email the lawyer? Do you have any emails between you? And all of that information material is discoverable. So usually they kind of give you those instructions, but some of the things that they will ask is, hey, don't make any notes, don't write anything down. We'll have a phone call with you. Often what they will do is assess then the temperature of what you're going to provide for them. And if it's a plaintiff's attorney and you seem favorable to, what they think, they may hire you beyond this initial review. Any phone call, anything you do after them is on a per hour basis, half hour per hour. I think the thing of this is, and I feel like it's been very helpful for people. I know for me, after that initial review, I tell them the truth and say, look, you guys are in trouble. And the sooner you settle this, the better, because this is egregious. This is horrible, and it's not going to go in your favor. And that's partly, if not all, of what they are looking for in an expert witness. And I have had plenty of cases end there when you are able to sort of lay out the case for them, how they're really going to get burned and how open and egregious it is. But this is a pretty common fee structure. It's pretty reasonable, and some of the cancellations and things, I have never myself ever had to go to trial. These always settled and have settled in my case. But you need to have contingencies for if you have to go to court, you have to do these things. And you probably should, when you're starting out, if you get one of these requests, talk to the legal department where you are, or whether it's your practice, your academic institution, to see if they do have any policies surrounding this and instructions for you.
Thank you. I also, you mentioned the thing about emailing. So as an expert witness, you can't put on the subject line attorney-client confidentiality privilege. If you put that and you're the defendant, or you want to do something back and forth, that is not discoverable if you mark that. But as an expert witness, you don't have attorney-client privilege, and so that that's just, again, just something to create a distinction of. All right, moving on. Documentation. Okay, this is I think that this has some important merit to it. I think that this is something we could spend all day on, and it's hard to really nail down what is the absolute answer, because there isn't an absolute answer, but I think it's really important to consider. One thing I wanted to throw out there: what's the role of the multidisciplinary team? To be a sarcoma center, you actually have to have a multidisciplinary team that meets on a regular basis, all at the same time, discusses the sarcoma cases with multiple disciplines. And most of us document that. So this was an interesting article out of Australia that talked about what is the medical legal ramification of a multidisciplinary cancer care center when you sit around and you talk about all these things. And one of the important things that I think that we fail sometimes to really document well in our notes are dissenting views. It's not all happy and everybody's singing Kumbaya every single time, every single case. There are different ways to do things. And the summary of this article, you can read this, but it was interesting to say that suggestions were you should get at least a verbal consent from a patient to say, hey, I want to present you to the multidisciplinary cancer board. And I do that in a very informal way of saying, hey, I just we'll plan on putting this on the board next Monday morning, and I'll plan on getting in touch with you Tuesday morning when I have some time to make phone calls. That's that, and I've never had a patient say no, but you're going to be discussing their case in front of people that don't know them. There's going to be HIPAA issues, etc. What is the legal ramification if your name is in the record and that patient files a lawsuit? You were part of that multidisciplinary team, and these are all discussions that, again, no major answers, but I think this is actually a pretty interesting article to just look at and say, what is the role of documentation of the communication that we have with our partners of different disciplines when we're doing this? So what is your role as a surgical oncologist when you are documenting, and what is your role as you're shepherding this patient through this journey? Well, you're the first line of diagnosis. Okay, and we went through all of this. You're ordering all the basic studies. I would say surgeon or orthopedic oncologists and a lot of our fellowships, we train to do the surveillance, to do the initial, to recognize and then order all the basic staging studies, and then to get them ferried off to all of our partners. We perform exams. We document the timeline of events. We create the follow-up to bring the patients back. We obtain all the hospital records. We're kind of the mules to bring all that stuff. We obtain the pathology tissue. We are that first line of diagnosis. I think the second important role is we're the quarterback. We submit these patients to the tumor boards. We arrange for the multidisciplinary appointments. We call, hey, my medical oncologist, I have this patient coming from Mississippi. You know what? They have a diagnosis of a sarcoma. It's metastatic. Can we make sure that we have you on their agenda? I think that's an important thing. And then we're following up on the tests that we scheduled as the first line diagnosis to make sure that they're actually done. Oh, this was dropped because of some insurance hiccup. Like, it's my job to make sure that there's not a delay. And then most importantly, or just as importantly, I should say, is that we are following up on all of our studies and communicating. And I think that's where some of these delays have the potential to occur as surgeons, is you get so busy that your in-basket gets logged behind. And if you're not religiously checking this and calling patients back and being communicative and personally viewing the imaging, not just trusting a report that's, quote, normal, but personally going through it, that's when you can get yourself in trouble. So I think all of that is incredibly important, and patients will remember the doctors that take the time to call them during the day, after night hours, to be communicative, to be upfront, to be blunt. They'll remember that when they're thinking about, did something happen that shouldn't have? No, it couldn't have, because this person is like the best human being that I've ever seen, because they care about me. Okay, really, really important. When patients come, and a lot of patients, they have no idea that something may have gone wrong. And there are some patients that have a pretty good intuition. And this is not your opportunity, if you see that there's been a potential breach in standard of care, to vent, not in front of the patient. You should refrain from giving your opinions about what the other treating providers did. Okay. If the patient starts to have questions, you can give pretty nebulous answers. And if they really start to pound you, you can say, listen, like, I really think that this needs to go through appropriate legal channels if this is what you're trying to search. But this is one of my go-to lines. Sir, ma'am, I'm really sorry. I honestly can't speak to this care, as I wasn't directly there. I wasn't part of this decision-making process. I would like to just focus on what we're doing looking ahead. We can't change what happened in the past. Let's make a plan for you and get the best care possible. Really kind of turning the tides and changing their focus in their direction. This is an example of a note. And if you actually take the time to read this note, it's laughable in so many ways. Going back to the concept of like the red flags of soft tissue sarcoma, a large, deep mass, 10 centimeters. There's about 35 misspellings in this, including a ST elevation, MI anesthesia. I mean, you go through this and you're like, this is absolutely laughable. There's no grammar, there's no periods. And you just read this and you're like, how on earth could somebody who's competent have done this operation? The only thing that wasn't done was it wasn't a transverse incision, thank God. And, this is an example of how I documented this. Okay. I said, this is a very aggressive cancer. There was gross tumor or microscopic tumor left behind. We talked about what the ramifications are for this and what we would do if we didn't intervene, how we were going to figure out to make a plan, what potential risks may be, who I may need to involve to help do this. But one of the things highlighted in gray that I want to highlight in this particular incomplete excision is I want to throw a silver lining in for the patient. And I make it very clear, and I tell them, if we will get you the right plan of care. Let's gather information. And if this is treated appropriately in the aftermath, this does not affect whether you live or die from this cancer. It does not worsen your overall survival. It can take a lot of anxiety away from a situation. And most importantly, I have a follow-up plan. So I have met, if you look at informed consent, if you look at things that kind of help avoid tort, I have tried to address every single one of these. And then number 8, calling that physician. I do try to call physicians on a regular basis. I look them up on Google. I send a message to one of my friends at the same hospital. You know, it's whatever it may be. I'm always kind and I sympathize. I'm really sorry that you got stuck in this position. Like, hey, I'm Nate Mesko. I wanted to reach out and just let you know what we got your patient. Thank you for the referral. Offer constructive feedback. You can educate. It's okay. You're not trying to be professorial. You can give your contact information and you can confirm it's okay to take over on the patient. I've never had anybody say no. And you know, this is again another comment, another line that I have is, hey, listen, literally, the next time you see one of these lumps or bumps, send it my way. I don't want you to have to deal with the stress of having to go through this again. Let me take care of that stress for you. Just send it my way. Here's my phone number. Here's my email. One of the questions that you can ask is, what the heck do you do with repeat offenders? I have one particular surgeon who has now sent me 5 incomplete excisions through either bone or soft tissue sarcomas, and it's to the point where, like, emotionally, I have anger every time I see a note from him now. You know, I don't know what the right answer is, and I figure that you guys may have some questions about this, because this is a tough scenario to be in. Okay.
Nate, I'm just going to reiterate that point that it kind of goes back to what I was asking before, that, you know, when you're the young surgeon coming out of training and you think you know everything and these patients come in really unhappy, it is so helpful for them to diffuse the situation, just like you said, and put your, you know, personal bias behind and remember that standard of care, that those people out in the community aren't subspecialists like we are, and it will save you a lot of headache and help the patient move on more easily. I used to get so fired up and give them the name of a plaintiff's attorney and really, like, you know, how dare they and whatever, and have found it to be much easier to do exactly what you said. Step back, diffuse the situation. Yeah, you're in good hands. We'll take good care of you. Sometimes when I call the physician or talk to them, I say, you should call the patient and just follow up with them. They're mad, they're unhappy, and it will do you a long way to get out of litigation if you give them a follow-up call and tell them we talked and you're worried about them. I even coached them through that, because that really helps get them moving in the right direction, just like you do.
Yeah. Absolutely. Make yourself available. I get calls from physicians who they get the pathology report and they realize that they screwed up and they start freaking out. What do I do with this? Listen, let me coach you. I know how you call the patient. You don't need to give them a ton of information. You give them my name. You tell them, well, my office is going to contact them tomorrow morning. We will take care of all of this, and I will keep you in the loop. You will get business that has nothing to do with cancer. You will get the small lumps and bumps, which are filler cases, which let you kind of run your day, which also adds some RVUs. You'll maybe get some total joints or trauma cases. Like, you will have a friend if you treat these people who are in a tough situation, these physicians, your colleagues, in a compassionate and graceful way. All right. Don't be afraid to ask questions. You can interrupt me. I got 2 more topics here. I believe it's 2 more. Being on the wrong end. Okay, so you're in the hot seat. Okay, you're the one getting sued. All right. Couple things. 1, do not panic. Okay, just because you get served. So what happens is generally, not all the time, but generally you get some kind of a document that says there's about 180 day. It's usually a 180-day period where a team is determining whether or not there's enough merit to move forward with a lawsuit. Okay. And that does not mean you're being sued. And that oftentimes, if you're a hospital employee, will go to their legal department. It will come to you if you're a private practitioner, in which case, obviously, you involve your legal team. Obviously, you immediately call your counsel, your attorney, your institutional legal team, whatever that may be. Never, ever. I'm going to go to the very bottom, the last point. Never, ever, 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 ever go back and start changing things in the medical record. Okay. Do not delete. If you have to add something, strike, but do not ever give somebody the chance or the chance to think that you're trying to cover something up. Okay. You be vulnerable and you open with your attorneys. Your attorneys are your friends. And then when this communication, remember we talked about the expert witness that Dr. Holt was talking about, when phone calls and what's discoverable or not. Do not text or email. Everything is discoverable. Okay. If you do have to do something, especially an email, write confidential attorney-client privilege. That then becomes protected. Okay. And do not discuss this outside of anywhere other than a potential public appropriate forum, quality assurance or morbidity mortality conference. All of our we have at our hospitals. That actually goes in your favor if it's discussed there, because you're trying to learn. Your hospital, your department, it recognizes this and are trying to improve so that this doesn't occur again. Okay. And always follow institutional procedures for disclosures to patients. Okay. I think the art of being able to tell patient bad news, especially when you're the one that caused it, is something that nobody ever teaches you. It's something that is really hard the first time, the second time, the third time. It never gets easy. It does get easier. Okay. If that 180-day period moves forward and you say, you know, we are filing for a lawsuit, okay, that's okay. Do not discuss this case with anybody, okay, other than your attorney. And be prepared that there may be some valleys and hills, up and down roller coasters. There may be changes in the trial schedule. And as Dr. Holt suggested, as we'll see with the literature here, the majority of these cases actually will settle. Okay. But be prepared that this could go to trial, which drags things out. Any questions? Okay. I've even had, so into the day of the medical records, I've had attorneys, our legal attorneys on cases that I've gotten that 180-day letter. I've never actually had a lawsuit go forward beyond that, but I've had a few 180 letters, and they will actually say, like, it's okay for you to go back and look at the medical record, but understand, like, your keystrokes are logged, the amount of time you spend in that chart, the pages that you were on. So it's no longer a paper record. It's like literally everything can be looked at and followed. So again, never ever give the impression that you're trying to hide something. It's okay to be familiar and to refamiliarize yourself with something, but don't be seen as somebody whose integrity can be questioned. Okay, and this is an example I had. This is not a sarcoma case, but this was a straightforward atypical lipoma. PIN was involved. That's the fun exam you see 3 weeks later. You're rolling your eyes. This guy's like a roofer. I document exactly what happened. And, I said, I want to see you back in 2 months. I've reached out to one of my hand surgery colleagues. I didn't put his name in the record at the time because I just wanted to say I've reached out to him. We've talked about how we rectify this with transfers. We've talked about how we identify some diagnostic imaging with an EMG. I've set up an occupational therapy appointment at this time. I'm going to walk him over there. And then 3 months later, guess what? Still the same exam. That sucks, especially in a guy who's a construction worker. He has had no recovery. I'm not trying to hide anything. I've given him 2 options. I've said we can use a dynamic, a dynamic splint, or I can send you for that EMG we talked about and get you set up with my hand partner. I called him. I said, can I use your name? Yes, you can put my name in the record. Absolutely. Steve, thank you. Here's the option. Here's the surgery I would perform for you. I will get you in with him. So I've literally gone through absolutely everything, the follow-up, the thought process. I've owned it. I'm going to walk through this journey with you. This is one patient that I got the 180-day letter and they dropped it. And, the attorneys at our particular institution said this was absolutely perfect how you went through this, because you really showed that you didn't drop any, you really cared about what happened to this patient. Okay. So that's a good example. Any questions? That goes back to the documentation part. All right, last part. This is the last section here. Okay. How about musculoskeletal oncology specifically? Okay. So I think there's there's different buckets. So this is a famous article from the Yellow Journal. Okay, what happens when you see an isolated lytic lesion? Well, the majority of these are going to be metastatic disease. We know the three families of cancer. Sarcoma is obviously the very rare one of these three families. Okay, but this is one particular thing that potentially we could get involved in if a lytic lesion is recognized and a nail is put through it, etc. Open biopsies or missed biopsies or mismanagement of lumps or bumps is certainly something. And one thing I will always say, especially with your training, and I tell my residents, I tell general surgery residents that rotate with us, always trust your gut instinct. If something doesn't smell right, believe the alarm bells in your head. You are trained. You have enough training to know that you've built this subconscious alarm bell system. Okay. Sarcomas are kind of another third thing. It's an international level. We've talked about the fact that years and tens of millions of pounds and dollars have been spent, and we still have the same problems 2 decades later. Okay. We've done this in the United States. MGH showed this. Okay, so we have 16 years of trying to educate and trying to put out in our highest impact orthopedic journal, like why we should be doing biopsies at the institution that would do the primary tumor changes. And what happened after 14 years of attempted education? Absolutely nothing. Nothing changed. The amount of amputations, the outcomes, the complications, etc., or the referrals. Okay. So it's a problem not just in Britain, it's in the United States, it's everywhere. 3 papers I want to just mention. Okay, this was the first one, 2014. This was 216 patients over 3 decades that we looked at. There were sarcoma-related claims. Delayed diagnosis was the reason for 81% of these claims. Okay, that will be a common theme as you see. The most common injury complaint, okay, was wrongful death. So injury complaint would be wrongful death. The second most common was a loss of limb. Okay. And the most common people sued, by far and away, over a third, were primary care physicians because of delays in diagnosis. Oh, that's just a fatty tumor. Don't worry about that. General orthopedists, primarily because they didn't read their imaging. They just looked at the report, not because of surgical mishaps. Radiologists, and then general surgeons. Okay. Interestingly, and here's an important fact, if sarcoma-related claims go to the jury, and as Dr. Holt had mentioned, like, it's important that the expert witness is very upfront. If it goes to the jury and you don't have a good case, look at the award difference. It's massive. It's at least twice as much, and more than twice as much. Settlement, that's why a lot of these settle, because people understand, like, once it gets to the jury, now you have a motion, now you have punitive damages in play, especially if the state doesn't have good tort laws. It's a problem. Okay. And that's not just this paper, that's some of the subsequent papers that we look at. As we said, the most common reasons that the lawsuit is brought, delay in diagnosis, by far and away number 1. Unnecessary amputation, interestingly, a distant number 2. And if you look at this, the payout, you would think that I lost a limb because of something, that would be the most egregious sin. Well, delays in diagnosis still had a higher payout. Okay. This is just a chart of the most common folks. We already went through this sued. Okay. General orthopedic surgeons and primary care physicians were the top 2. Okay. And that is a common theme. Again, delays in diagnosis, 81%. Okay. And you can see the average award for a sarcoma payout as compared to the general population of that same specialty. So $4 million award payout for orthopedic surgeons, $230,000 average orthopedic lawsuit. And that was based on this NEJM article. All right. This is in the United Kingdom, same common theme. I just want to point that out. 90% of cases that were brought as a lawsuit were because of delays in diagnosis. Back in 2020, using a different law base or a different legal database, Westlaw. The first one was LexisNexis. This was by the UCLA group. 90% of cases were because of delays in diagnosis. And the same theme, primary care physicians, general orthopedists, radiologists, and general surgeons in that order were the most commonly sued. And the final slide that I will leave us with, and again, this is that silver lining that you will be able to give 1/3 of your patients in your sarcoma, soft tissue sarcoma practice, is that there is no clear evidence to suggest that a patient that has an incomplete excision is directly linked with a loss of chance at overall survivorship. If I can rectify this, I can decrease your risk of local recurrence to baseline, and you are not more likely to die from this cancer. Okay, I think it's a really important thing to know, especially when you're on the expert witness stand, or if you're stuck in, if you find yourself, I've had an incomplete excision accidentally before on a small thing, but it still is a sickening feeling. You know, it's an important part of that patient conversation to have. Okay, so that's my final slide here. I'm happy to field whatever questions you want. Hopefully this was a good resource.
And I'm going to add one mistake I made as a young doctor was having I don't know if you've ever had this, but I had a patient who had come to me with a path fracture, and it was a giant cell tumor of the distal femur, but she ended up needing a mega and didn't have any issues, but had wanted to sue the physician. And she asked me to talk to her lawyer, and she really got involved in trying to get me to, to help her. And I made the mistake falling into it to say, oh, sure, I'm happy to talk with, whoever you want me to talk to. And basically sat down with his lawyer, who put me in an expert witness situation that I certainly wasn't expecting. So, you've mentioned it several times, how being careful in ensuring that things go through your legal team. And I've gotten written letters from patients saying, hey, can you help me with my disability because of this doctor, whatever. And every bit of that needs to go through your legal team. Don't let the patient and your relationship with the patient and wanting to make them happy pull you in when you really shouldn't.
Yeah. And I'll even add further to that. The answer is yes. We now have patients have unlimited access to us. They can find your email, my chart on Epic. I've had a patient who, like, I'm not kidding, sent 30 plus messages with lawyer and legal questions on asking me to give my expert opinion. And I finally had to ban them from my chart and say, you must call this phone number to ask these questions. I cannot do this. They can call your office. They can send handwritten notes. They can get to you however they want. And the most important thing to understand is the attorneys are on your side are actually an incredible resource and a huge buffer, a protective buffer to you. Use them, see them as that, and let them go through all of the nonsense so that when it comes to you, when that conversation actually does include you, you can focus on what you're good at. Well, I really appreciate the invitation to talk on this. I think it's not necessarily the sexiest subject in the world because there's a lot of legal terms, but I think it's a really important subject that we all have at least a basic grasp on. I think it's also something that we should all understand that we are comrades in the trenches together with this. We will, there's a point in time where we will probably be having to have conversations with lawyers, potentially about people that we know and friends. And I think it's really important to know how to act professional, how to protect ourselves, and how to be very much of that diffusing entity, that peacemaker in these situations if we're involved. Hopefully you can use this as a resource, and absolutely, as always, we'll make our contact available, and please feel free to reach out, phone call, email, etc. You guys are the future of our society, and we're really excited to have you on board.
Hey, thank you. Well, you guys know our the next topic is actually dealing with difficult complications, Doug McDonald just retired from his 40-year orthopedic oncology practice, is going to talk to you guys and answer questions about how to deal with tough cases and go through some tough cases and that sort of thing. Nate did not disclose his wife is a lawyer, so for all of the lawyer talk, he is married to a lawyer, so nothing but love there. So
is
thank you.
Dr. Holt.
Yeah, thank you guys, and we will see you next time.